Hi there, Care Prevention, and welcome to Chapter 15. Like I said in Chapter 16, I like to begin at the foot and work my way up through these chapters. And so we're now in Chapter 15. We're going to talk about the knee. This video is specifically dedicated to acute injury of the knee. And so I'd like to begin with the first one on our list, and that is knee sprains. Remember, a sprain is something that or an injury that occurs to a ligament. And so with ligamentous injuries, many times we think of kind of a lighter injury. But when we get to the knee, we find out that knee injuries can be a little more involved when it becomes a sprain. And many times you don't even hear the word sprain when you hear of some of these. And the first one I'm going to talk about is that big sprain. That big knee injury, the one that most basketball players fear the most, and that is the ACL, or the anterior cruciate ligament sprain. And so to understand sprains, we have to understand some of the mechanics that were mentioned in the above video about the anatomy, and that is the first term, valgus, and the first two terms, valgus and varus. And so what I have here is a model of a knee, and you can kind of see that this is a left knee. And so we are going to identify those terms a little more. Valgus simply means that the distal segment of a joint will move laterally. And varus simply means that the distal segment of a joint will move medially, so this way. And you know from those from the video above what the term medial and lateral mean now. But let's do this. Let's imagine that in a sport such as basketball or football that you have planted your foot. And if you plant your foot, and I hope that you'll do this with me at home, you'll plant your left foot. And when you plant your left foot in the ground, now I want you to imagine that your knee is going to bend. Something like you were turning to receive a pass from a teammate. And when you planted your left foot and you're rotating to your left, your tibia is planted and your femur is now externally rotating on a fixed tibia. And when you do this, typically if your foot stays planted, your ACL will begin to unwrap and tighten, and that's when an ACL injury occurs. It takes typically valgus and rotation to cause an ACL injury. And so the mechanism of injury for an ACL is valgus and rotation. Now, the ACL, when it is torn, typically tears completely. There are times where there are partial ACL tears, and I've seen several of those. They're really difficult to detect on a clinical exam, and you're going to see down below a video, and it's about the Lockman's exam, and it's how to perform a Lockman's exam. And I'm not asking you to become proficient in doing a Lockman's exam. I'm just simply giving you the information as to what that is. But a partially torn ACL is very difficult to pick up. A full ACL tear is pretty easy to pick up, but you have to get to them pretty quick. That Lockman's exam is great, and it's the best exam out there clinically for an ACL tear. But when an ACL tear happens, if you don't get to them and do that pretty much within about the first 60 to 90 seconds, you're kind of going to have to forfeit and not expect to pick up that exam. And it takes time and lots of experience to really appreciate a torn ACL with a Lockman's and get that test down. So the next thing on our list is an MCL sprain. And this happens almost the same way as an ACL. Typically, though, there's no rotation, or there's some kind of a traumatic insult that occurs from the lateral side, causing that valgus motion to occur. Remember, that's the lateral movement of the distal segment. And so that tibia is now moving laterally. Again, it could be fixed, but typically we see a fixed moment in the tibia, and then the rotation, the valgus actually occurs at the femur, which is this big bone right here, right? And so when it happens, it tears a ligament that is located right here on the medial side. That medial collateral just gets stressed because of that lateral motion of the tibia, and you tear your MCL. Now these happen, and rarely are these an injury that requires surgery. And so that brings me to this point. The MCL doesn't always need surgery, but the ACL, tucked away right in here, will. And that is because the ACL and the MCL have very different anatomical locations, and the ACL is intracapsular, meaning it's inside a joint capsule, and it doesn't get a very good blood supply, and so it just can't heal. And so that's why we have to go in and we have to fix or actually reconstruct ACLs, where the MCL is out here on the outside, and it gets a pretty good blood supply. Now, it takes a few weeks to heal. And let me get into that just for a second. The MCL, typically 6-8 weeks, will come back and return. Most of the time it will need a brace, specifically a hinged brace is preferred for an MCL injury. An ACL injury, again, it has to be reconstructed. And the time from reconstruction to return to play is typically 6 months. We usually don't even let people return to running for 3 months, and that's a straight ahead run with no cutting until about 5 or 6 months. And so return to play is a very long time. And you know, because you probably watched a lot of professional sports or college sports, and you keep up with this, that an ACL injury is typically devastating to a person's athletic career. The next one on our list is the PCL. And the PCL is a ligament that's located in the back. So I'm taking my left knee and I'm turning it around here, and it's in the back of the knee. And typically it's injured because someone flexes their knee and then they have trauma that occurs to the tibia. So it would be a lot like falling on a bent knee, or maybe even having a motor vehicle accident and your knee hitting the dash. And that tibia translates posteriorly, and it just pops that posterior cruciate ligament. Again, this is not always an injury that requires surgery because of its location, but sometimes it does. It really kind of depends on the severity. Like a grade 3 will typically be repaired, but a grade 2 and a grade 1, they'll let it heal up. So this injury is pretty well picked up off of a test that we use called a posterior drawer. And I'll lay the patient down and I'll pick that knee up and kind of just push. And what I'm doing is I'm pushing this way, and I can literally take that tibia and translate it back, and that posterior drawer, it's like closing a drawer, will shift. And the ACL, which is still intact, will be the only thing that catches it and stops that knee. I can also take that knee up and bend it up like this and do a 90-90 test, and what you'll have happen is the tibia will actually sag. It's called a sag test as well, but it will sag down, and you have to do both knees to see this. But the PCL deficiency will let that tibia just slide down. Again, that's another brace-it-up injury when you return them to play, but very different type of bracing than the hinge brace for the MCL. Looks a lot more like the ACL return-to-play brace, but they're very effective, and they really help to stabilize that knee. Next thing on our list is patella dislocation. And the patella sits out here. It's a sesamoid bone, which means it's a free-floating bone, and it's kind of held down by the quadriceps tendon that comes in from the quadriceps muscles, and then it forms a patellar tendon and inserts here on the tibia, right there on that little green dot. So this is not a very common injury. Most of the time, someone has some pretty significant trauma, like they were hit on the side of the knee, or they fell and hit their knee. But when they do fall and hit that kneecap from the medial side will slide out, and it will land somewhere out here on the lateral side, and their knee will be bent. And what you'll look for is a deformity. And when you get to them, they'll say, "My knee popped." And you know, that's not a good sign. If your knee pops, it's usually the ACL or MCL. But they'll say, "My knee popped." And when you get to them, you'll find that kneecap is literally sitting out here on the lateral or the outside of the knee. And it's a really simple fix. I'm not going to tell you to do it, but it's a really simple fix because typically you just extend the knee or straighten the knee and it pops right back in. Now, I would not recommend that coaches reduce dislocations, but what I would tell you is that once it goes back in, that person's going to feel a lot better pretty quick, and they're not always going to be able to return to play, so please don't expect that. But it will happen that once that kneecap goes back in, they feel 100 times better because it's sitting out there and it's pretty tender and painful. The next thing on our list is a meniscus injury. And what I'm talking about here is the cartilage or the padding that is located here on the tibial plateau. And what we're looking at is a small, very thin piece of tissue that absorbs shock, and if you didn't have it, your knee would hurt all the time. A meniscus injury happens because of typically a weight-bearing and rotated mechanism, and it just nicks a little piece of that meniscus. Now, depending upon where it's at, many times a physician or a surgeon will go in and they'll just take out the little piece of torn tissue because it doesn't heal. It's like the ACL. It's inside a capsule or a joint capsule. And so it's sitting in there, and the joint is going to be tender, and sometimes it will lock. I've seen many times where a person's knee will lock and they can't extend it because the meniscus tear happens and then it flips over, and so they have a locked meniscus. And that's not good because if you can't straighten your knee, you can't walk right. And so typically you're on crutches until you get it fixed. But what we know is that that injury keeps that knee from straightening many times, but they'll have popping, they'll have catching, and they'll want to almost tell you, can you pop my knee, because it feels like it needs to pop, but that's that meniscus being flipped over. And that's usually a surgical procedure to get it repaired. But again, the surgery is not that big of a deal. They go in, they clip it out, and almost in 4 weeks, a person is back to doing what they want to do. The difference is if they have to repair it. If they go in and they actually sew it back together, then that person is not going to return to play for maybe 8 months, depending upon the severity of the tear and how long it takes. But they don't really repair a lot of meniscus anymore unless it's a very young person. So the last thing on our list down here, you can see right here, is Bursa injury. Bursa injuries occur when someone is hit in the knee, like by a baseball or by a helmet. And when they get hit, what happens is they rupture a bursa. And a bursa, specifically the suprapatellar bursa, will bleed or let a lot of fluid off into the knee, and so they'll get this big swollen up knee. Now, there's only 3 times where a knee will swell up really big. And that is if they tear their ACL, if they pop a bursa, or if they fracture a bone. That's when the knee swells really big. Every other injury typically only has localized little swelling, like the MCL over here, or the PCL will have a little swelling in the back. But if they have a big hemarthrosis, a big swollen bloody knee, that's an ACL, that's a fracture, or that's a bursa. You're hoping for the bursa because the bursa is pretty easy to fix. You wrap it up, you ice it up, you give them a few weeks off, and you let that bursa heal up. Most of the time, a physician will go in with a needle and they'll aspirate that bursa after 7 to 10 days. Once the bleeding and the initial bleeding stops, they'll go in and they'll get that blood and that leftover synovial fluid off, and a person feels great. Now, you have to protect that just like you do, like you brace an MCL or you brace an ACL. You have to protect that by giving them some kind of a knee padding because they're really susceptible for the rest of their season typically for another bursa rupture. And so you don't want that to happen because then again they're out for 7 to 14 days. So that is acute injury of the knee. We're going to move now into chronic injury in the next video. Looking forward to seeing you then.